Air Vice Marshal Retired Dr. Rajvir Bhalwar. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. He obtained Air Vice Marshal Retired Dr. Rajvir Bhalwar. Our dean has obtained very tall qualifications.
कॉपी करायला लागत होतो याचं डेस्कटॉप पेन ड्राईव्हमुळे होत असं पेन ड्राईव्हमुळे होत असं सर स्लाइड आले सरांची
हां स्लाइड असतो
आवाज भीती पाहिजे करून
Good morning.
Good morning to one and all. It is my privilege and pleasure to present to you our Dean, Air Vice Marshal Retired, Dr. Rajvir Bhalwar. Ladies and gentlemen, Air Vice Marshal Retired Dr. Rajvir Bhalwar has a rich professional experience of over 43 years, including 37 years in the Indian Armed Forces. Our Dean has obtained very tall qualifications, and that too from very elite universities and educational institutions, which are listed amongst the best institutions in our country by various top-level bodies as NIRF. He obtained his MBBS from King George Medical College, Lucknow University in 1976. He completed his MD in Community Medicine from Armed Forces Medical College, University of Pune in 1984 and PhD in 2001. He also underwent 2 years full-time postdoctoral training in clinical epidemiology under the INCLIN program at KGMU from 1992 to 1994. He obtained the PG Diploma in Hospital Management from AIIMS New Delhi in 1991, followed by PG Diploma in Medical Laws from Bangalore in 2014. He was awarded the prestigious fellowship of the National Academy of Medical Sciences in the year 2012, and he also holds the certificates as NABH Assessor, ACLS Provider, and Aptech Computer Professional. Dr. Rajvir Bhalwar has many honors and awards to his credit. He was awarded the prestigious Dr. Dhanukar Best Medical Teacher Award of entire Maharashtra University of Health Sciences in 2008. He was awarded commendations on 4 occasions by Government of India for exemplary services in medical care, teaching and administration. He received the Defence Minister's Trophy as Commandant of the Best Hospital of the Armed Forces. On as many as 12 occasions, he has been awarded the Best Research Work Award from Government of India and national level bodies. He has been the recipient of Certificate of Honour in Preventive Medicine as an undergraduate. He was awarded the WHO SEARO Director's Dr. C. Mani's Gold Medal for the Best Intern in 1977, and he was adjudged as the Best All-Round Student of the King George Medical College in 1976 and was awarded the Rolling Trophy for his achievement. He has undertaken a large number of important teaching appointments, where at present he is the Dean, Rural Medical College of Pravra Institute of Medical Sciences, deemed to be University LONI. He has served as a professor and head Community Medicine in Armed Forces Medical College, Pune, and Army College of Medical Sciences, New Delhi. He has worked as Principal and Commandant, Command Hospital, Bangalore, and Principal, Dean and CMS, IQ City Medical College, Durgapur. In addition to the teaching appointments, our Dean has a wide variety of experience of hospital and medical college administration. He has been the Medical Director of the Apollo Hospitals, Hyderabad, JCI accredited, with 1000 beds. He was Commandant, Command Hospital, Bangalore, with 800 beds, super specialty and teaching hospital. He is an expert member of Union Public Services Commission, Government of India, and an expert advisor for the National Disaster Management Authority, Government of India. He is also an MCI assessor and a member of MCI Curriculum Committee. Dr. Bhalwar is the chief editor and the lead author in a number of very prestigious books, some of which are already prescribed textbooks in the syllabus of various universities, including Maharashtra University of Health Sciences. He is the chief editor and lead author of the Textbook of Community Medicine, published in 2009, and the third edition, published in 2019. He is the sole editor and author for the Preparatory Manual for MBBS for Community Medicine, published in 2018. He is the author for the chapter in the API Textbook of Medicine of 8th, 9th and 10th edition. He is also author of 5 chapters in Textbook of Environmental Medicine, published in 2015. He has contributed immensely in the research work with 75 published papers to his credit, 55 out of these listed in PubMed and 20 on Scopus. He has undertaken 8 large-scale research projects from ICMR and DRDO. On as many as occasions, he has been awarded the Best Research Work Award from prestigious national bodies. Besides all his achievements in academics, teaching, research and administration, our Dean has been an excellent sportsperson. He has represented Army formation at Command Athletic Meet in the event of javelin throw in 1980. He has been sports officer in Armed Forces Medical College for 6 long years. And he is a recipient of college colours in badminton in 1975 and represented Lucknow University. Last but not the least, ladies and gentlemen, presenting to you at a glance all the achievements, awards and honours bestowed upon our Dean, Air Vice Marshal, retired Dr. Rajvir Bhalwar. Thank you.
At this point, I take this opportunity to wish all of you a very, very happy 2021. To you, your parents and your families. And I'm sure that this new year will bring a lot of happiness and your dreams will come true. I also take this opportunity to compliment all of you on your marvelous achievements, and which is evident from the fact that all of you are the proud students of one of the most reputed and prestigious institutions of our country, the Rural Medical College of Bhavar Institute of Medical Sciences. The fact that you are here as our students is a reflection of the fact that you must have worked very, very hard and with great objectivity to be here. And I also take this opportunity not only to compliment and congratulate you all, but also your parents, because behind your success is their commitment, their hard work, and the fact that they have decided to give you the best of education and support you in all manner. So with those few words of welcome and congratulations, we will start on a subject which is usually not very well touched upon, and that is professionalism. Now, professionalism is a topic which is very often spoken. Very often we find people saying there should be professionalism, we should be professionals. But then the point is that what is professionalism? How do we define professionalism? And that is what we go on to discuss today, and also to see what are the facets, what comprises professionalism, and why it is important for the medical students to start becoming a professional, to strive being a professional from the day one. So ladies and gentlemen, boys and girls, let us start with the definition of professionalism. There are a number of definitions, but what I feel is the simplest and maybe the most suited for us at the beginner's level is that it is the attainment of the highest level of qualities that are expected of a particular profession. In other words, the person who is a professional is something like a master of his or her profession or job or business. And professionalism in general would include a few qualities. Firstly, there should be a commitment to excellence. It comes from within the heart. Ethical practice, responsiveness to the people around you, and of course, a great sense of accountability to your patients, to the community to which you provide care, and to the profession. Or in layman's terms, a professional is one to whom, once he or she, the client, has assigned his or her task, the client would feel carefree. The client would feel fully assured that the best of results would come. A patient who comes to you and considers you as a professional after entering your office or entering your operation theatre, the patient is perfectly happy, sure that you will do the best and you will drag the patient out, even out of the most serious disease. Now there is an old saying that when in the epic Mahabharata, when both Duryodhana and Arjun had gone to seek the blessings of Lord Krishna before the war, and Lord Krishna gave them a choice. The choice was that either on one side, one party selects him, and that too unarmed, and the other party would get his entire army, the finest army that time in the world. And he says since he saw Arjun first, he would give the first choice of selection to Arjun, and Arjun selected Lord Krishna. Whereas Duryodhana was heart of heart very happy and he got the army. So subsequently, Lord Krishna asked Arjun, Arjun, why did you ask for me? And that too, I am unarmed. You could have asked for the entire army. And Arjun's reply was that, Lord, when you are driving my chariot, I'll surely find my way. And if the way doesn't exist, I'll create it. So that is what a professional means. Now, we would wonder whether from this pair of Lord Krishna, the charioteer, and Arjun the warrior, who was the professional? Somebody would say Lord Krishna, somebody would say Arjun, but the fact remains that both were in their own right top professionals. Lord Krishna was a professional strategist, a professional in policy, planning and strategy, long-term thinking, whereas Arjun was a professional in the art of war. So these are the epitomes in our own mythology of professionalism. From my side, over these many years of experience which I have gained personally in my own life, and also the experience which I have seen my friends, colleagues gaining and learning from their advantages, their successes, my own failures, and of course the failures of my friends and everybody in the world. To summarize for my young undergraduate students at the very beginning, I would say that professionalism can be structured, and what constitutes professionalism would be the Navratnas. You remember Akbar the Great, the emperor, had Navratnas in his court. There were 9 ministers, 9 jewels, who used to advise Akbar on various aspects of policy, strategy, day-to-day functioning and so on. And similarly, for professionalism, what I feel is that these are the 9 jewels which start from the letters A, B, C, D, E, F, G, H, and the 9th one is I. And these are ones which I will deliberate upon. Each and every one of them is important. There is nothing which is higher in precedence, which is lower in precedence, but this A, B, C, D till I have put in order of alphabets so that it becomes easy to understand, easy to remember, You need not cram it up, but the point is that each and every quality which these letters indicate, we all have got to practice them, gradually practice them, make it a part of life. And once they become part of our life, we are on our way to becoming a top professional. So let's start. Now let's say what A stands for. A stands for three things. A stands for the attitude, A stands for availability, and A also stands for appearance. Attitude, the first thing, is the way you are predisposed to various aspects in life. How you think, how you react involuntarily is your attitude. It indicates a positive thinking. It indicates a will to do a task. It indicates a will to win. There are the people who would think a very positive attitude, they would think nothing is impossible, or just the four words, I will do it. And that failures won't stop me, but I'll certainly learn from them. Not that I'll overlook my failures, I'll learn from them. Why did I fail? But at the same time, I'm not going to stop. So that is what attitude is. And extremely important for a doctor, that all of you are a doctor in the making. And these are our, I would say, the first few days you have just started this very sought after career, a very noble profession. The first thing you should develop is a positive attitude. Have attitude of doing things. Have attitude that you are going to achieve it. You are going to do very well. And that is very important. Don't have negativity influencing you. A also stands for availability. And remember, boys and girls, this is an extremely important quality which you should develop. For a patient, what is most important is that a doctor should be available. If you are there in the outdoor, if you are there in the emergency department, it makes little difference how well qualified you are. What makes a difference for the patient and for the relatives who have brought the patient is that whether you were there or not. You may be the best surgeon, you may be the best cardiologist, but if you take 2 hours to come after the date of appointment or the day of appointment, the time of appointment, it's not worth it. If you are on emergency duty and you are not there, you are sent a call, you are not there and the patient is writhing in pain, waiting to be operated, your entire competency will go down. People will think that you are not a good doctor. Therefore, make it a part of life. It is a part of professionalism. All doctors who have been successful in life, who have been appreciated by the community, by the patients' relatives, are the ones who made this a point. Whenever they were on duty at a given place, at a given time, they are there. This is extremely important, and make it a habit. Gradually make it a habit, because over these years I have also seen the most competent doctors, the most competent specialists and super specialists who gradually failed in their profession just for one thing. Not they were not competent, they were extremely competent, but due to the fact that they were just not there. And the immediate message which goes to the patient is, to the community, is that you do not care. And once the community starts thinking that as a doctor you do not care, your entire practice, your reputation, everything goes down. And A also appearance. A also stands for your appearance, the way you look. This I need not deliberate too much, but I would like to say, boys and girls, that the society looks at a doctor through a very different prism. As young boys and girls, you may be thinking that putting on faded jeans, toned jeans, having few stubs on your chin may be looking mod, because a few cine stars are that way. But remember, a patient, the patient's relative and the whole community, the members of the community whom you provide health care, do not look at you from the prism they look at a cine star or they look at a movie. For them you are a doctor a person who is very different, who is noble, and the first thing is how you appear, the way you dress, the way you appear, the way you walk, the way you talk. A lot of people would say that when an interview is conducted, it may be for a small job or it may be for a very big job, but almost 1/3 of the marks are actually allotted before you start speaking, because the interviewers, who are very seasoned people, they start making an impression of you from the point you enter the door. How you have dressed up, whether you have shaved, whether your hair are kempt or not, whether you have wished, are you smiling. So that is what constitutes appearance, and I would suggest that to be a good, successful and professional doctor, take care of your appearance. It's extremely important because that is the first impression that you cast on your teachers, on your patients, the relatives and the family members of the patients, as well as on the community that you are going to educate, the community with which you are going to interact on healthcare matters. So that is about A. It stands for attitude, it stands for availability, and it stands for appearance. Now let's go on to B. B stands for behavior. The patient, do remember one thing, that the patient has come to you. Why is the patient known as a patient? The patient is a patient because he or she is in pain. He or she has got some symptoms. And in fact, the patient is a patient because he or she requires the doctor to be patient. And therefore, one of the biggest quality of a good doctor, which indicates that this doctor is a professional, is that you should be very well behaved. A good behavior with the patient, a good behavior with the relatives, the way you are speaking to them, the way you are explaining the disease management to them, or your understanding, or even if you are referring the patient to some other senior doctor, that entire thing constitutes your behavior. And behavior as such is a very, very important thing in the society, very important aspect of the society as a human being, particularly in a civilized society. But when it comes to a doctor climbing up the ladders and going and becoming a professional, behavior counts a lot. How you behave with the patient. And all of us who are at now my level have known so many examples of very good doctors, extremely well qualified, very competent, always available, full of knowledge and competence, but we are not able to reach that highest level because they were not very well behaved. At times they would recur to the patient, they will shout at the patient, they will maybe abuse the patient or the relatives. That is what actually decides, one of the points which decides that whether you are going to be successful in your medical profession is how you behave. So take care of that, of this B. B for behavior. Behavior includes politeness. It does not mean that you bend backwards or you do a shashtang before everybody. No, it does not mean that. You need to be upright, you need to be firm, you need to uphold your medical values and ethics, but at the same time you just have to convey them in a manner which is pleasant, which is, a old saying is Satyam Bruhat, Priyam Bruhat. So you speak the truth, you speak the facts, but speak it in a way that is appeasing, that is acceptable, and which does not hurt. It indicates humility. Once again, humility does not mean that you start crawling before people. You have to maintain your self-esteem, but humility at the same time means maintaining a self-esteem but not going into that state of being egoistic. Not going into the state of saying, I am the doctor and what are you? That is not worth it. A good behavior means humility and politeness. Now let us go on to C. I would put C like I put A. It stands for 3 qualities which gradually take you toward professionalism. C stands for 2 qualities which again you need to develop. C stands for competency. And C also stands for communication skills. Now, what is competency? Competency is the essential factor which every doctor worth his or her salt has to have. If you are not competent, if you do not have competency as a basic doctor, what we call, and we will make you a good Indian medical graduate, or the competency of a specialist, then probably the word used is quack, which certainly nobody would like to be. But how does competency come? Competency is just simply a combination of two words. It is reading and practice, practice and reading. Both the things are important. Both the things are important. You should continue to study. A medical profession is ever changes, keeps changing overnight. A year from today, when I am sitting here on 13 January in 2020, we were just hearing there's something like COVID. It's happening in Wuhan. Today, you know what a world of difference there is. So, it's an ever-changing world, and it means that every professional doctor must keep on reading and keep on practicing. And when you practice, go back and read of something new that you have found out in a patient or in the community. And once you have read the things again go back and apply it on practice. A old saying is that theory and practical are both important. And they say that if you only mastermind theory but no practical, if you are only theoretician but you do not have any practical application, then it's still tolerable because you are a philosopher. A philosopher only reads theory things, the practical application is very little. But the worst part is a practice without theory. Because if you practice without theory, without knowing what you are doing, then you become a quack. Because you will keep on doing things because you are very practical, but you will keep on doing the wrong thing because you don't have the theoretical background. Both are very, very important. And therefore what I say is continued reading, continued practice, stay abreast with your profession. You will become a basic doctor, the Indian medical graduate, then you will become a specialist, a physician, surgeon, a public health specialist, an anatomist. Then some of you will become a super specialist, you will become a cardiologist or a neurosurgeon. So whichever level you are, keep abreast with the knowledge. Keep reading, keep practicing, and keep putting all this knowledge and skills together. Don't let them go waste. You have to keep on consolidating them and keep on moving forward. That is what competency is. Communication skills have become extremely important. When you talk of behavior, communication skills are a separate set of virtues which you have got to develop. How you communicate. Communication skills are not simply behavior. Behavior is an attribute. But communication, you may be having a very good behavior with people, but you may not be able to communicate. You may very well behave, very polite, very have full of humility you are. But when your patient, who is from a rural area of, let's say, either from Maharashtra or West Bengal, and the patient does not know any English, and you start talking to them in English or use a jargon of words, you are polite, you are very well behaved, but you are not communicative. And communication itself needs a lot of qualities. You have to speak slowly, you have to come to the level of the audience to whom you are communicating. When you become a medical teacher, you become a professor, you become head of department, you become the dean, then also you will have to communicate. And the first thing in communication which will take you across gradually is that you must identify your target audience. Identify the characteristics of the audience to whom you are going to communicate. What is that person or the group of people? What is their background? What are their preformed ideas? What is their educational level? What is the various things that they understand? What are these culture and customs? If I am taking your undergraduate class I must understand your level and what you need. And then I got to formulate that material in a knowledge, in a method that you can understand. If I start talking to you at a level which is a specialist level or a super specialist level, I am not at all communicating well. I am only speaking. Fine. So, for a doctor, communication is an art, and which any doctor, if he or she strives to become a professional, has to develop, of course, all these qualities. Develop very, very slowly. You will take a few years, and one of our objective in your medical education for the next 4.5 years, and followed by 1 year of your internship, would be to gradually inculcate all these values and all these qualities in you. But ultimately it will be your continued effort. Every day you will need to practice to get these good qualities of becoming a professional. And as far as the communication is concerned, you should start making a habit of good communication, effective communication from the very first day. D stands for two things. One is discipline, the other is documentation. Now, discipline is a very vague term. We all have different understanding of discipline. You may be thinking our dean is a retired air marshal, so discipline means only standing erect and saluting, and like on the Republic Day we have crisp marching. That is, yes, that is a part of discipline, but discipline is a very big thing. Discipline is actually a way of life. How you live your life, how you conduct yourself. It involves so many small things. Getting up properly at time, doing your morning exercise, wishing people, coming on time, dressing up properly, having your schedule with you, eating properly, everything is a part of discipline. And ultimately, I would summarize, it's a method of self-control. The difference between human beings and non-human animals are also very faithful. Animals are also can be very, very good fighters. They can be very aggressive. They can be very physically fit. But the difference is that animals don't tend to be disciplined, whereas human beings are disciplined because they have got a self-control, a mechanism of self-control. An animal, when it is hungry, it will grab the food or it will eat another animal. But a human being has got that much of discipline and self-control. Even when he or she is hungry, they will bear the hunger, but they will not go and eat, they will not steal, they will not commit a theft and just for eating, or they will not eat each other. So it's basically a self-control. Deciding what you have got to do, what is correct, and then exercising it in a manner that you do away. There will be a lot of feelings. Let me not get up in the morning. Oh, leave it today. Let me not go to the classes. So what happens if I miss out a clinic? No, but that is all a part of discipline which you have got to inculcate. You have got to first of all draw your boundary. This is what I am going to do. I will do that. And this is what I will not do. And once you have drawn these boundaries for everything, that everything could be getting up morning, sleeping late, going to the classes, not going to the classes, being there in time, being there as a doctor in time, drinking alcohol, smoking tobacco or not drinking alcohol or tobacco, whatever, you have to make out your boundaries. This I'll do, this I'll not do, and then you have got to exercise your self-control on whatever you have decided. Discipline is actually lifestyle. How you look at life, how you live your life is all but discipline. If the society thinks that your lifestyle is not correct, it is indiscipline. So that is how you define discipline. Health becomes a part of discipline. You will find people who are healthy in real terms, they are the ones who are very disciplined about everything. Their exercise, their food, their avoidance of narcotics, the way they get up, the way they exercise, everything. They follow a pattern and they stick to it. So first thing, for a doctor, you must be very, very disciplined. A doctor who is not disciplined is a doctor who is probably not going to go very far as success is concerned. The second aspect of D is documentation. Now that is very important. You may be thinking that it's little premature for me to talk about the importance of documentation to just the beginners, the greenhorns of medical education, but this is the right time that I must talk to you for a couple of minutes. See, documentation means whatever you are doing, you should put it on the paper or on an electronic system, because you have a lot of laptops and everything. But a document is a record of what you have done, of what you are planning to do, and a record which is not destroyed, which does not evaporate, which remains there for years and years. I have got experience seeing my many colleagues, and all your teachers who will teach you, they all have this experience. Many of the cases of medical negligence against the doctors go down, and the verdict goes against the doctor, not because the doctor had not taken care. The doctor had taken best of care, the best of treatment, very professional doctor, competent, everything. But the doctor did not properly document it. And so after 5 years, when the case goes up before the honorable judge, before the honorable court, and they say, where is the document, produce the case sheet, and you say case sheet, when the case sheet comes, the case sheet, nothing is written, or something is written, then it is cut off, or some eraser is put. They say no, it is not correct. So remember that and make it a habit. From your very first year, you start writing what you are doing. When your clinical postings will start, just after a year, when you enter the third term, you will be posted to various OPDs and IPDs. Make it a habit of documentation. You will see the case sheets, you will see the OPD papers, you will see the investigation forms, everything. Be very clear, write it down there. These are the set of symptoms or the complaints the patient has come. These are the additional symptoms. A short, crisp note on these are my physical findings on the patient. A note on the investigation results, the treatment that I have given. Then after 3 days, again the patient has come. This is my follow-up. The patient has improved. These are my findings. This is what I recommend again. Write it down. Keep it as a record. That is a very, very important aspect of a successful doctor. Don't use your mind as a notepad. The mind has got a lot of other things to store. Many of us, we feel that we'll keep it to the mind, we'll remember. It doesn't happen. After 5 years of forget. Because there are many other things, important things which replace that in the mind. And in any case, if it becomes a legal issue, then nobody is going to believe you that it is written in my hair. No. They want it written on a pad, on a case sheet, on a OPD prescription. So be very particular about the documentation. It's one of the very important steps towards achieving professionalism. E in today's world has become extremely important. When we were students, it's almost 50 years back when I started, 1972, my undergraduations, what you have started now. We used to basically and very commonly used term was IQ, the intelligence quotient. The intelligence quotient still remains. You all are intelligent. You have proved your intelligence quotient by doing very well at your NEET examination. You are here in a med college, and that very fact is a reflection that you are having a very high IQ. But in today's world, what is also become equally important or maybe more important than IQ is your EQ. What is your emotional quotient? And now another thing which is coming up in a very big way is the SQ. What is your social quotient? So, besides your intelligence, have a clear thinking that you should react in a proper emotion. It doesn't mean that when a patient comes in pain, you also start weeping. That is not emotional quotient. But responsiveness, feeling the pain, and that is where the difference between empathy and sympathy comes in. I have also put E for empathy. Sympathy means that you feel pain at the other person's pain. If the other person has got a problem, you also start weeping, you also start crying. If the other person is having lack of money, you pull out the money from your pocket or give it to him, or else if you don't have money to give him, you start crying. That is sympathy. But the better thing to do in life is empathy. Empathy is different than sympathy because it means, it's simply defined as putting your feet in somebody else's shoes. And then you will realize what the problems are really of the other person or the other community. It's very easy to say. A patient comes to you or you are giving a talk to the community members, it's very easy to say, eat lot of protein, eat lot of chicken and eggs because they have got lot of protein, easy to say. But then put your feet in their shoes. Try to understand what the community level is, what is their income, what is their education. If the community members or that family is hardly earning anything to make the two ends meet, it is not practicable, it's not doable for them to eat 2 eggs daily or give 2 eggs daily to every member of the family or give cheese to everybody. So empathy means understanding what the root cause of the problem of the patient you are treating, of the family of that patient and of the community of that patient is, and then formulating your guidance, formulating your management principles, formulating your treatment plan according to that. And that is very, very important. You have a patient, if you are not empathetic, you may be a very good doctor, you may be disciplined, you may be competent, you may be very good at documentation, but you are not empathetic, you are not understanding other person's problem, you are only understanding the symptoms. You are only understanding the investigation results, or you only understand what is there in the CT and MRI report. Well, you may not be very successful one day because the patient will not be able to follow your advice because you have not understood the patient's actual condition, and the patient will go to some other doctor who gives a better advice, the more doable advice. So remember being emotional, correctly emotional, not carried away by emotions, but being emotional and being empathetic. This is another very important landmark for you to become a professional. So these are the things which are, and also esprit de corps. Now this is a military term actually, which said that a team, a corps in a military terms is a team. So having that spirit of the team, I am a doctor, I am a surgeon, I have my OT matron, I have my team of my OT technician, I have my anesthetist, then the anesthetist agent is assistant is there, then I have my OT nurses, we have the scrub nurse, we have the circulating nurse, the whole team. So that spirit of the team must come in. I don't work as an individual, and there is where all of us as doctors, and you particularly as newly commissioned doctors, must work hard, because doctors generally tend to work as individuals. I am the doctor, I am telling you to take this medicine, fine. But then when it is a part of team, when it is part of medical community, when it is part of the surgical team, when it is part of the entire medical team, you have to inculcate and you will have to assume the role of a team leader. You will have to understand the problems, the strengths and weaknesses of each and every member of your team. And then you will have to manage all of them accordingly so that the whole team functions. You remember, in today's world, even if you are very good, but if you are not managing your team well, you may not be very successful because your team members will fall apart. So, E stands for your emotion, your emotional intelligence or the emotional quotient. E stands for empathy, understanding the problems of the other party, and the esprit de corps. F stands for following the standards. Now again, this in today's practice of medicine is extremely important and will count a lot towards the fact whether you become a true professional or not. When we were students, those system of protocols, SOPs we have never heard of. A senior doctor, if I am the professor of a subject, I am telling you this thing, do that. So that was done. Now the system of medicine is changing. We are going on to standards. What you will hear a very commonly used term, the best practices, or what is evidence based, or what is in the protocol. So understand the protocols, and that is where the follow the standards come in. There are standard operative procedures. When you manage operation theatre, there is a standard operative procedure for a operation theatre, for the disinfection of a operation theatre. There is a SOP on the way the instruments are to be sterilized. There is a full procedure written down. These are all written laws. They are not laws, but they are procedures which must be followed. Then you have protocols. You have clinical protocols. If you have a patient of COVID, the protocols are drawn. You examine the patient. If these symptoms are there, but these signs are not there, then the patient is a mild case, and these are the drugs, and this is the monitoring system. If this is also there, if let's say the oxygenation is falling down, or there is evidence of chest involvement or lungs involvement, then these are the medicines, and these are how we are going to follow up the patient. These are all known as protocols. They are all written, and they are like strong binding facts, the best practices. These are also taken from evidence, and the evidence based. Today everything is evidence based in the practice of medicine. If it has come out from evidence, it is evidence based. For example, there has been a lot of discussion. We are starting vaccination. In the ideal situation, it comes from evidence of a phase 3 clinical trial. However, we are in a situation when we cannot wait for the results of clinical trial. So emergency use authorization of the vaccines have been given by various countries, including our country. That's fairly acceptable. But by and large, in routine circumstances, whatever investigations you are doing, whatever treatment you are giving, and whatever follow-up you are giving, or else whether you got to refer to another person or not, all these aspects are based on evidence which are published on some research. So standards would mean standard operative procedures, the laid down protocols of management of a disease, or the health problems of a community at large. It will mean the best practices which are there for any institution of repute, and what has come out in the evidence. And they are all known as the standards, and you must follow these standards. Don't deviate, because if something goes wrong with the patient, firstly it is not good. Things should not go wrong with the patient whom you are treating, because it hurts you. It hurts the patient, it hurts me also. And more equally important is the fact, if things go wrong, then you should be able to sustain yourself. You should be able to justify. And during justification, two things will come up. Did you document? You will say, yes, this is the case sheet. Was this document, whatever you have given as per this document, was it correct? Yes, it was correct, because this is the protocol which has been laid down by a professional body, and this is what I have done. So, follow the standards. Now, this is something which is not taught generally, no book writes it, but you must understand this. G. Have a love for God. Whichever religion we follow, ultimately the goal of every religion is that we all become good human beings, and the fact that every religion teaches us that there is a supreme power beyond us, and this supreme power controls us, controls the destiny, and at many times when we are in distress or somebody else is in distress, the supreme power may be able to help us out, may be able to resolve the situation. And that is what we should always understand. So, whichever religion we follow, have faith in the religion, have faith in the values. And today, another important aspect which has come up in the world of medicine is the practice of spirituality in medicine. And it is now a fact that there are now chapters being written on spirituality in medicine. Spirituality does not mean propagating a religion, but spirituality does mean that understanding the religion, understanding the power of the Almighty, praying to the Almighty for the good of everybody, and being a good human being, that we do good. And therefore, one thing you should do as a potential medical doctor, having started your medical career now, take out some time, any time, whenever, whichever is convenient to you, could be morning, could be evening, night, whenever, take out a few minutes and pray. Pray to the supreme power in which you believe, could be Paramatma, could be Guru, could be Allah, could be God. Whichever supreme power you believe, take out time, pray. Be thankful for what you have got and ask for whatever you want. And ask the supreme power to give you strength so that you treat your patients well, you live as a good human being, and that your patients and the community also lives healthily and happily. So that is G, and this is the one which I say H. H stands for honesty and ethics, and I stands for integrity. There is a difference between honesty and integrity. Honesty is judged in the more material sense. You take a bribe or you don't take a bribe, so you are honest or dishonest. But ethics and integrity go beyond that. There is a difference between law and ethics also, which you must understand. Law is a written set of rules which are formalized by a nation or a state, and then you can be penalized for not following it. For example, there is a MTP Act, Medical Termination of Pregnancy Act. There are certain provisions in that act, and if you do not do it, you do something contrary to it, you can be penalized by way of fine or by way of jail, whatever is written in the act, if you are found to have committed a crime. But ethics are those which are even unwritten laws. Ethics are those, for example, wishing good morning to your teacher, saying good morning, Ya Ram Ram, or Shabak Khair to your parents. If there is no law on that, nobody can put you in a jail for not doing it, but at the same time it is accepted by the society. That are ethics. Integrity is your oneness, whether you can be broken easily or not, and that is the ultimate. It includes your honesty, it includes your resilience, it includes the way you are strong enough to face the difficulties and still not being led away by things which are immoral. So that is what H and I, H honesty. I need not deliberate on it. Gradually you will also learn. You are already enough grown up to understand what honesty means. Only thing is that what is very important is that you need to follow honesty in life. Honesty of conduct, honesty in your profession, honesty in your personal life, ethics in your profession and personal life, and above all, integrity. Have integrity. So boys and girls, this is what I thought I'll talk to you, have one-to-one discussion. This is my first meeting with you, and definitely we'll meet more often. Once you come back to the campus, we'll meet physically also. And but these Navaratna which I've shared with you, probably they're not given in any textbook. These are all based on experience. My experience, the experience of my friends, and the experience of many others whom we just hear. But these are the 9 things which you must start practicing from today for you to become a successful doctor, and what we mean a professional in the true sense of word. These are the 9 principles. Gradually, and they'll not come overnight. It'll not come that today you started and tomorrow you are a full professional. No. All these principles will take a lot of time, a lot of painstaking efforts on your part to follow these principles to the point that they become a part of your life. It becomes automatically, they come reflectively from you. So, I'm sure that you will, I'm sure that all of you will do very well. You will reach the greatest heights of success on behalf of the entire institution and the management, your teachers, all the departments, the head of departments and the faculty, and all the staff, teaching and non-teaching staff of the Rural Med College, the prestigious Rural Med College where you are, of which you are the students. I wish you all the very best. wish all the very best to your parents. I compliment them once again for supporting you and bringing you to that point that you are the students of a very, very fine melt college. So all the very best. Once again, a very, very happy new year and wishing you a very happy LONI. And so many festivals are today. So all the very best for you. God bless you.
Students, so that was excellent session on professionalism by our respected Dean sir. And now the next session is by Dr. S.N.Mahajan sir. He is Professor and Head Department of Medicine. He has also done FAMER Fellowship from CMC Ludhiana and he is member of our curriculum committee. Now his topic is doctor-patient relationship. So over to Dr. Mahajan sir.
My dear students, I welcome you all to the folds of Rural Medical College of Bhavar Institute of Medical Sciences, deemed to be university. First of all, congratulations for getting admitted to the institution who is of repute, who is guiding the students for last many years. It is accredited A by NAC in its accreditation process 3 years ago. I am supposed to talk to you on doctor-patient relationship. Now, before I go on to talk on this topic, I have a question for all of you. Why have I chosen this profession? You ask this question to yourself. When we have entered the medical college, that time also the same question was asked to us, and the reply of all of us was only one prototype similar, and the reply said, we are in this profession to serve the humanity. Now, to say so is very easy, but if we follow this in letter and spirit, if we are there to serve humanity, then nothing more is required, and my lecture on doctor-patient relationship is also immaterial, is not required. I must say so. But when it comes to practicing medicine, when we go out in field to practice and to deal with the patients, this thing we usually forget, that we wanted to serve the humanity, and for that we have chosen this particular profession. Alright, we must have chosen this profession because in this profession our future is secure. And let us admit frankly, but this is a noble profession and the responsibility is on our shoulders to keep it a noble profession. Lot many distortions we see as of today, and many people blame us for not following the things which we should follow. So in next, over a period of half an hour or so, we'll be discussing what should be the relation of doctor and patients. Now here, the types of doctor-patient relationships are depicted in this table. Now here there are 3 columns and 3 rows. On column number 1, patient control. Now whether it is patient's control or doctor's control, it can be low or high. So low patient control or high patient control, it can be low doctor control or high doctor control. Depending upon that, low patient control and low doctor control means what? That means default. We'll discuss it one by one in detail. Second situation is patient control is high and doctor's control is low. This becomes a consumerist doctor-patient relationship. Now the third situation is where the patient's control is low and doctor's control is high. This becomes paternalism, paternalistic approach, and type of doctor-patient relationship is paternalistic. And last and fourth thing is where patient control is high, doctor's control also is high. When both of them have got high control, this becomes mutuality. So we'll discuss all these things in detail. Types of doctor-patient relationships, just now I said, they can be paternalistic, mutuality, consumeristic, and default. Now here, for ages, we have seen paternalistic approach towards doctor-patient relationship. What does this mean? Doctor acts as a patron and patient control over the situation is very, very low. So whatever doctor says, patient has to follow. Usually, patient doesn't ask anything, does not ask any question, no queries on his side. He doesn't inquire about the diagnosis, what treatment, when I will be alright. At the most he can ask how much time it will take for me to be alright. But he does not inquire about his illness and the drugs which are being prescribed to him, what will be the prognosis long term and all that. So here this becomes a paternalistic approach. In the past, we have seen that this approach was being followed for decades together, where doctor is the center of attraction and patient he just listens to whatever doctor says. This becomes a paternalistic approach. Now here, things are changing nowadays, and now with this change situation, the doctors have to keep themselves updated, and the patients, they also have started learning things through the internet, and they are inquisitive about their own illness and they ask questions, and they go through the internet and their symptoms, the disease also, and what is the prognosis, what are the various differential diagnoses, how to investigate this condition, how to treat this condition, and what is the prognosis. All this to some extent they know, but internet does not teach them everything. Ultimately, it's the doctor whom he has to come to know about his illness and to get his illness treated. When patient knows so much about his illness, so just now I said the role of the patient, as I said, patient's control and doctor's control here in this approach is equal. Both control the situation to a higher level. So high control on the part of doctor as well as patient. Now this becomes a mutual approach towards treating the patient. Now here doctor has to keep himself updated, be prepared to answer the patient's queries, patient's questions, and do not get irritated if he asks silly questions or serious questions. Whatever he asks, you have to reply to their queries in a suitable manner so that your patient gets satisfied. Now these sessions may be many in number. Ultimately, the patient is handing over his life to you. Now you have to satisfy him before and during starting the treatment. Before starting the treatment, whatever his queries are there, you must satisfy them and then start treating him. During the course of treatment also, whatever he asks, you have to reply to his queries, and then only he will develop trust in you and will take your treatment and continue to be your patient. So this becomes a mutual approach. mutuality. Now the third variety of relationship is consumeristic. Now in the consumeristic, this particular approach, what happens is the patient dictates. The patient takes over the control of the situation and he dictates. Doctor, might be suffering from this. I know these are the treatment possibilities. Now you tell me which treatment you are going to give me. I feel this is the best treatment, so you must give me this treatment. Now here, doctor has got low control over the situation. Further, since he knows something about his illness, he might well ask you, doctor, do you feel you can treat me, or else you refer me to some other specialist or some other hospital. Now when the patient asks for that, you do not have much choice. Now there are two types of approach here. One is you explain him that you are able to treat his ailment and you can treat him. In this approach, if he gets convinced, you treat him, but your responsibility will increase. Here, if the patient does not improve, or if he develops some complication, he is likely to blame you that, doctor, I asked you to refer me to a different specialist or a different hospital, and you said you will be treating me, and with your treatment I am not all right, I have developed this complication and all that. So this is one aspect of it. And the second thing is, since he is asking for a referral, you refer him. Now there are situations where unless you refer him to a specialist, he will not get reimbursement, or such complicated situation may arise, and if you refer, your role becomes like a postman. He has come to you, a letter has come to you, you have to deliver to a particular place. Not only this much, many times they just come to you, take prescription from you and take a bill, and there are certain hidden agenda of the patient on this. Third thing which can happen is they will ask for only medical certificate from you so that they can get leave. Now these are the situations where we must not succumb to the pressure of the patient. We must judiciously use our knowledge and our skills and discuss with the patient. If he doesn't need 10 days leave, why should you advise? Now in lieu of that you are paid, is alright, but payment is not the only thing for which you are in this profession. So please be careful on this. And this third type of approach which we have just now seen is not a good thing to have. And the fourth approach is a default. Now here the patient has come to you, he is not much bothered about what is happening to him, he is bothered, so he has come to you, but what is the diagnosis, what is the treatment protocol you are going to follow, what treatment you are going to advise, give him, he is not inquisitive about it. And moreover, you are also not much interested, I will not use this word, you are not much enthusiastic to explain your patient what you are doing. You just complete the formality. He has come to you, you diagnose his condition, give him prescription, and the patient goes. So this is default, and this goes on. But such an approach will not last long. Your patient will not come to you for longer period of time in this situation, because there is no dialogue between you and him. By default he has come to you, by default you are treating him. So this is not a correct thing. Just now I have told you 4 approaches on this. What do you think the best approach is? Now the best approach is mutual approach, wherein both the parties sit together, discuss the ailment, and then they decide the line of treatment. Now that is the best thing to do. Patient knows what is going to be done to him. You know what you are going to do, and you have discussed with the patient. You have discussed pros and cons, the side effects, the complications, all that you have discussed in detail with the patient. Therefore, this is the best approach you can have in dealing with the patients. So, mutuality is the best thing. Now we move on to a phrase coined by William Osler. William Osler. What he says is, a good physician treats the disease. The great physician treats the patient who has the disease. Now, here you are not there to just treat the disease. You are dealing with a human being, and you must treat a human being. He has come to you, he has handed over his body to you, his life to you. You must deal with him in a proper manner. Now just to tell you one example. The time doesn't permit, so otherwise I would have quoted many examples. Now example I would like to give you. A patient develops a small boil on the lower limb, on the foot. There is an infection in the lower limb at foot. All of us during our childhood have received trauma or boil on the foot while playing, get traumatized, get secondary infected. Now the patient goes to doctor. He tells him that doctor, I have got a boil on the foot. Now the diagnosis is right. He feels there is a boil. Now he gives a prescription. Now the prescription contains an antibiotic, one painkiller, and one multivitamin preparation. He hands over the patient the prescription. Now the patient wanted to tell him that my limb is aching, I feel like feverish, I don't feel like eating anything, but doctor doesn't have time or doesn't pay much attention towards his complaints. Now since he is not satisfied, he goes to some other doctor. Now that doctor asks him, what are your complaints? Now he tells that I have got pain in the dorsum of the foot, there is some boil, I have got pain on the foot is alright, but I have got more pain in the inguinal region, I feel feverish, I don't feel like eating things, and my whole body also aches with this. Now here the second doctor asks him to lie down on the couch, examination table, examines his foot, then examines his inguinal region where the lymph nodes in that region are inflamed and palpable. All of us have this experience. When there is limb on lower limb, there is some infection in the inguinal region, on the upper part of the thigh, the part which joins the abdomen and thigh is known as inguinal region. There is a pain because there are lymph nodes which get inflamed. Now he records his body temperature, he examines his pulse, and after doing all this, he prescribes certain drugs. Now that prescription also contains an antibiotic, one painkiller, and another multivitamin tablet. Now the prescription is same, but after taking this prescription, he is satisfied, he goes home, next time he feels sick, his family members feel sick, or his relatives or his friends feel sick. Now you think over this and answer a question to yourself, which type of doctor you want to be, and this patient will refer his relative or friend or himself will go to first doctor or second doctor. Obviously he will go to a second doctor because he could satisfy him, he explained him what is his nature of illness, he examined him, he had time to listen to his all the complaints. The first doctor also had given the same prescription, but he could not satisfy him. So this is the difference in the approach, and therefore what Sir William Osler has said is true. Here next quote is, medicines can cure, but a good doctor's inspirational words can give the strength to fight from within. Now, do you agree with this? Now, a patient goes to a doctor. Now, he tells him, don't worry, I've diagnosed your ailment rightly. I'm giving you this treatment. It will take this much time for you to recover completely from your illness, and you will be all right. Don't worry. And then patient goes home, takes treatment. The other doctor, for the same thing, just without assuring him, he just listens to his complaints, maybe he examines him also and gives a prescription, take this medicine, you will be all right, without explaining anything. Now, our society and community, people feel doctor's words of assurance are very, very important. You can't be curt to the patient, and if you are really speaking good words to the patient and assuring him of the treatment and recovery properly, that gives better healing on the part of the patient. Therefore, this quote also I like very much, and we must talk to the patient in the convincing manner. This doesn't mean that for a serious patient also you should do the same thing. You assure the relatives and the patient that you will be all right, and your patient doesn't recover and he succumbs to the illness. Now, this is not the right thing to do. Now, your responsibility is to diagnose the patient's illness correctly, analyze the nature of illness correctly, what are the treatment options available, and you must narrate all this to the patient and relatives in a proper befitting manner. And for that, communication skills are very, very important. When you tell your patient all this, and if your patient is suffering from terminal cancer, you know you cannot cure your patient of his illness, but if your diagnosis is correct, then you will not assure your patient and relatives that your patient will be all right. What you will tell is, patient you will definitely assure in a different manner, but relatives you will tell the diagnosis and treatment options, and you will tell them this is an incurable condition. What we can do best is to relieve the pain or agony of the patient. As long as he is with us, he must remain cheerful. We must take proper care of the patient as long as he is with us. And here, with these words, if you talk to the relatives, you will not be blamed. Otherwise, you will be all right if you say, then there is a problem. Another example is, if your patient has come with the weakness on one side of the body, the partial weakness, he is able to walk with weakness, upper limb also is weak, and patient comes to you, you admit him and assure the patient and relatives that he will be all right. Next day your patient develops complete weakness on one side of the body. Now this situation does occur. Your patient was in stroke in evolution. This was to evolve and develop complete weakness. If you had known this before, you would not have assured patient and relatives that this is what is going to happen, that he will recover. Now if you were aware of this situation, you would have told patient and relatives, I will try my level best to halt the progress of the disease, but in some situation this is likely to progress and your patient will become paralytic on one side of the body in spite of the treatment. Now next day when he develops hemiplegia, relatives know that you have told them that this thing could happen, so they will not blame you. So these are all important things. Now here, duties of a good doctor. Now here important things are, patient must trust the doctors with their life and death. They are handing over their life to you, so they must have trust in you. And you must gain their faith. That is very, very important. to justify that the doctor patient must show respect to human life, there are certain headings. The heading number was knowledge, skills and performance. You must have knowledge of your subject, you must have skills to deal with the patient, and your performance should speak of your knowledge and skills. So these are all important things. Your patient should be the first cursor. Now in the past what has happened is, doctor was in the center of attraction. Whatever he does was the thing to matter. Nowadays the center of attraction is patient. So everything revolves around the patient, and patient is very, very important. And you must be able to provide him good standard practice and care. And that is possible with knowledge, skill and performance only. Now the patient's safety and quality of your care also matters a lot. Your job is to protect and promote the health of the patient. That you must be able to accomplish. Second thing is, take prompt action for the patient's safety and dignity. That also is very, very important. Your patient safety and maintaining his dignity also is equally important. The communication, partnership and teamwork. You should be able to communicate with your patient properly. Now here you are one partner and your patient is another partner, and both the partners are there working for the welfare of the patient. That we must know, and when we know this, then there is no problem. Then they treat the patient as individual and respect their dignity. Respect patient's right to confidentiality. Now a patient is suffering from an ailment and you go on telling 10 people that my patient is suffering from this and this. This is wrong. You must maintain confidentiality as far as patient's diagnosis, and whatever transpires between you and patient should be confidential. Then next is, work with colleagues in the way that best suits the patient's welfare. So it's a teamwork, and every member of the team should be taken into confidence, should be respected, and then only you will be able to provide proper care to the patient. The next thing is maintaining trust. Now this also is very, very important. You have to maintain your patient's trust, and for that you have to be honest, open, and you have to act with dignity. If you bring down your level, then the trust, honesty, openness and integrity, everything is lost, and your patient will no longer trust you. And never discriminate unfairly against patients or colleagues. All patients for you are alike. This is a rich patient, this is not so rich, so you can't discriminate amongst themselves. So you have to treat them as patients, and best possible care you have to provide them, and then only it will be possible for you to maintain good doctor-patient relationship. Never abuse your patient's trust. Every time we are discussing trust, honesty. You must trust your patient and he must trust you. This is a mutual thing. And if your patient doesn't trust you, you can't wholeheartedly treat your patient. And you must be honest while you treat. So all these qualities are of a good doctor, and I expect all of you will have these qualities amongst you when you pass out from this place and go in your practice field. Some patients recover because they have faith in doctors. And now this is said by Hippocrates. No person less than Hippocrates saying this carries meaning. And if you can win your patient's faith, definitely your patient will feel better and recovery will be faster. And you must have faith in these words which are said by Hippocrates. And keeping that in mind, if you deal with the patients, you are going to be successful clinician and doctor in your life. Now there are certain worries when it comes to good communication. So there are certain communication skills which one must learn and imbibe to be a good practitioner. On the part of a doctor, there are certain barriers to good communication, and the barriers are: if you have got authoritarian approach, if you behave like an authority. Now that was the thing of past. In the past, doctors used to slap the patient, and still the patients used to come to them because they had faith in that doctor. Nowadays this is, those days also that was wrong, and nowadays also it is wrong. So such a authoritative approach is wrong on the part of doctor. Dismissive attitude. Your patient tells you something, you dismiss it. No, you must pay proper attention to what he tells you, and then you try to explain him your point and discuss with him. Hurried approach. You don't have time for the patient, then why should he come to you? Isn't it? You must give proper time to your patient. Use of jargon, short terms, medical terms, you must not use while dealing with the patients. So you should be able to come to the level of patient and discuss with him and tell him certain things. Inability to speak first language of the patient, this is a big hurdle. Now patient language understands one language, you speak in another language, then there is always a communication gap. No experience of patient's cultural background. Now you must have understood his cultural background, and then accordingly you deal with the patient is very important. Now each and every point can take few minutes, and that much time we don't have at our disposal, so we'll just try to explain. I'll try to explain you things, then when you come here we'll discuss in detail. Now as far as patient part is concerned, naturally patient is anxious when he comes to you, so he may not be able to tell you at one go all his complaints. So slowly as he recollects, and he will tell you all the complaints. You must have patience to listen to him. Reluctance to discuss sensitive or trivial issues. He is reluctant. Now it is your duty. Now patient didn't tell me, so I could not treat his ailment. No, that is wrong on our part. It is our duty to get right things from your patients. So win his confidence, go into the details, and then he will open up and will tell you his all the issues. Misconceptions. He has got certain misconceptions about certain diseases, like jhadu tona, jadoo kar diya kisi ne, and all these things are still prevalent in our country in certain places. So you must be well aware of all this, and these misconceptions have to be dealt with properly. Conducting sources of information, further cognitive impairment on the part of patient, all these things which they are hurdle in good relationship. Hearing, speech, visual impairment, all these can happen more so with elderly people, and you must know how to deal with these situations. Another quote I would like to quote: the patient will never care how much you know until they know how much you care. How much you know, patient is not bothered about that. How much you care for the patient, how much you know how to care for the patient, that's what patient knows, and that's what patient will give importance to. Therefore, it is your duty to whatever knowledge you have, whatever skills you have, you must be able to implement in a given patient. Then only it is useful. Otherwise, tons of knowledge here, not able to use in a given patient is useless. Lot many skills you have, not able to use those skills in a given patient, all those skills are useless. Therefore, whatever you have, you should be able to implement in a given patient, and you must be able to give proper care to your patient. Now, this is a very important thing. There is lot of hue and cry on this particular topic, and that is CPA, Consumer Protection Act. Now, everybody, all doctors feel that this should not be applicable to our profession, because ours is a noble profession. No consumerism involved here. This is not we go to grocery shop, pay him something, in turn he gives us whatever we want. Our patient and doctor-patient relationship is not based on this. That's what we say. But what society says also is important. I don't say this should be applicable to our profession, but it has already been implemented and made applicable to our profession. Now, if it is so, it is our duty to see to it that to me this law is not applicable. And when I will be succeeding in this, when I develop good doctor-patient relationship with my patient, and he will not sue me in court of law, then this particular law is not against me. Not always we are at fault, therefore this law is implemented on us. That is also true. But we need to do a lot of introspection here, because there must be something wrong somewhere in this particular topic, that is doctor-patient relationship. If that was to go smoothly, then this act was not applicable to us. But something has gone wrong somewhere in the past, therefore it has come to force and is applicable to us. So it is our duty to see to it that how best we can avoid this situation. To a larger extent we can do that, but then certain situations are beyond our control, and these situations we have to face. But fortunately in our country such situations are less as compared to developed countries. Now, just to summarize, doctor-patient relationship, we have to build this over a period of time, and we must win our patient's confidence in us. He must be having faith in us. We must be honest with our preparation to deal with treating the patient. We must be honest with that. As I said, there are 4 types of relationships which we can develop, and these 4 relationships, either patient dominant, doctor dominant, or both of them are not at all dominant, and the best one is mutual relationship where both are dominant. So this is the best thing. But not all the situations one of the 4 is applicable. It could be a mixture of this, and more so if a patient has come to you in a serious condition. There you don't have much time to talk to your patient and relatives. You have to deal with the emergency situation and you have to treat the condition. And later on, after you have treated your patient's condition, the outcome can be good or bad, whatever happens. Later on you brief your patient and his relatives what happened and what did you do. So here doctor dominant relationship to begin with, later on mutual trust, and mutually you can decide what is the best treatment for the patient. Now, in a short possible time of say 35 minutes or so, we have discussed these matters: doctor-patient relationship, how to go about it, that we have seen. Since it's online discussion, there is no scope for question and answers. When you come here, if you have any questions, you write them, and when you come here in the campus, anytime, feel free to discuss with me on this. Thank you very much for your patiently listening. So when you come to the camp, I welcome you to this institution of repute, and thanking you for your patient listening. I thank the organizers, Dr. Pakhale, for giving me the opportunity to discuss with you on this particular topic. Thank you very much.
Yeah. Good afternoon, students. Now we have a session on Introduction to Skill Laboratory by Dr. Sandeep Pakhale, who is in charge of Skill Laboratory. He is also Professor and Head, Department of Anatomy, and he has also done advanced course in Medical Education is member of Medical Education Unit. Over to Dr. Sandeep Pakhale. And this session will be followed by one of the most interesting session, and that will be taken by Dr. Tushar, Bhavar and Dr. Akshay Shetty. And those sessions, you will see a lot of activity. You will see residency anesthesia and doing CPR, cardiopulmonary resuscitation on mannequins. So that will be very interesting session. So over to Dr. Sandeep Pakhale.
Good afternoon, friends. Good afternoon, friends. Today we are, I think, on the 10th day of the foundation course. I hope the foundation course will also provide a sound foundation for learning in the MBBS course and later in your professional career. Today I am here to introduce you to Skill Lab or Skill Laboratory. I think you all know that what is skill. Introduction of myself has been already done by Pakhale sir, so I will skip that slide. So introduction to clinical skill module. So what is skill? What you do? I have already introduced you with the three components of the learning, that is knowledge, skill and attitude. So out of that, skill part is very important. So there are three parts, for example brain, heart and hand. So brain is for the thinking, that is attitude component. The heart is for your emotions, that is the brain is for knowledge, then hand is for the skill. Here the aim of our session with you today is to provide you with an opportunity to consider ways of dealing with some of the challenges of communication and clinical skills you will face during medical education and practice. We have designed the session around some experiences that you are likely to have in the first year of the course. So today we are going to introduce you the clinical skill module. At the end of this session, we anticipate that you will be able to identify the skills that can be used when meeting patients for the first time in terms of both an initial consultation with a patient and when you have to conduct a procedure on the patients. You should be able to describe why awareness of your feelings is important during patient interaction, and you should be able to identify some of the barriers you may experience as a medical student when approaching patients on the wards. The clinical skills give intramuscular. There are few clinical skills that you must be aware of, that is intramuscular injection, subcutaneous injections, or carrying out the arterial blood sampling, the performing sutures. These are all called as clinical skills. Such clinical skills are many in medical profession. Another clinical skills, that is performing the bladder catheterization. All these clinical skills go hand in hand with communication skill as well. So the communication skills explain the need, explain the procedure to the patient or patient's relative, and this communication skill also help to be sensitive to the patient's needs. there is one terminology you may came across in the skills lab, that is simulation technology, which are used in the medical education. This simulation means mimicking the same thing. This simulation technology is a computer based technology or computer based simulation where the similar clinical scenario is mimicked on the mannequins, and it is usually in the virtual environments. There are some part task trainers also which are in the form of mannequins. Instead of doing directly on the patients, subjects or human being, first you will be demonstrated by the demonstrator on the mannequins or the task trainers how you go for, and these are called as mannequins or the task trainers. There are two types: low fidelity mannequins or the simulators, and the simulated and standardized patients are also there, on which they give history as well to you, and there are some hybrid simulations and high fidelity or full mission simulation. So these are called as simulators. As I told you, the knowledge, skills and attitude, the individual psychomotor skills, appropriate application of the skills, then communication, team performance, leadership skills and supervision and teaching skills, and also the assessment skills. So all these skills can be taught, all these components of learning, knowledge, skill, attitude can be taught on a simulated environment in a skill lab, on the mannequins, task trainers and the high fidelity and low fidelity simulators. So knowledge can be tested there, the skills can be improved and tested, and also the communication skill and the attitude of a medical professional can be tested and learned in the skill lab. The teaching best practice in a skill lab is learner centered, and appropriate use of technology is there while learning in the skill lab. And also the assessment best practice in a skill lab is or have got more validity, and it is more reliable and it is reproducible. So all the criteria of the best assessment are fulfilled in the skill lab. That's why skill lab is very important in medical education. We take one example. Today we are going to demonstrate you the basic life support. Here I am taking another example. For example, endotracheal intubation. For doing this endotracheal intubation, this is learned on a patient's under anesthesia previously. There was no special consent. They were used to learn this endotracheal intubation on cadavers also. But nowadays we use mannequins for the endotracheal intubation to practice. Here duty of care to protect the patient from harm. That's why we shifted nowadays from directly on the anesthetized patient to the mannequins and the simulators. This, if you do on the patient, there is increased risk when performed by a student or the trainee who is not perfect in the skills. So all the students and trainee should do or should observe on a mannequin, should do on observe, then should assist and then to perform on a patient. So this is the method while adapting the skills. For endotracheal intubation, needed by many health professionals, including anesthesiologists, paramedics, then emergency medical trainees, rural general practitioners, emergency physicians, ICU staff, respiratory therapists, etc. And here the competency requires is practice over the mannequin. So when and how should endotracheal intubation be taught? So endotracheal intubation can be taught on the animals, but nowadays due to animal laws we cannot go for the animal training. Then you can do on unconscious patient, but you can do on the newly dead or recently deceased patient, so that the anatomy of the larynx and different parts will be same as in living. Then newly dead, recently deceased, I told you. Then you can do on cadaver, where little bit distortion of the anatomy is there due to the shortening of the musculature and contraction of the organs. And you can do on the simulators as well. So most preferred method nowadays to practice on the simulator. Now what is skill lab, how it will be? You can see in this picture there is a skill lab on which we have kept the different mannequins or the task trainers. These are called as task trainers. Here the environment is provided which is quiet. There is no distractor there, because in real life scenario, in wards or patient, there are many distractors. The patient is not cooperative. He may not give consent to practice over his. So this environment comparatively to wards and clinical scenarios is quiet and there is no distraction. You can use the clinical equipments which are ample in the lab. You can expert the tutors. You can have realistic models on which you can do all the procedures first. There are many different models, as I told you, from easy, difficult to very difficult, so that if there is a difficult situation while doing the procedure, you also able to do the procedure properly without any mistake. So in a skill lab, the learning environment is very learning. There are different types of the mannequins or the task trainers. For example, CPR, cardiopulmonary resuscitation trainer, then adult female. Here then there are defibrillator, then little Annie, then there are pediatric cardiopulmonary resuscitator. So all these, and there are few basic mannequins which are used in different clinical scenarios. Now we'll come to the anatomy of the simulation. What are the components? First thing is that the components of the simulation, these are, you require student, that is trainee, then health professional who want to learn the skill. Then you should have a procedure or the task or the skill or the test or treatment or the equipment, wherein in a chart manner or in an algorithm manner, and you should go through the theoretical part before going into that. Then there is a patient and or disease process, and then there is another part is trainer or the supervisor. So these are the four components of the simulation. Then function of each component, there is a passive environment in which we can enhance the setting of realism. Then there is an active, you can change in a programmed way so that there can be an active environment. And the third one is the interactive environment, which respond to the action or the event. the trainees learn, for example, cricothyrotomy on a part task trainer. You can see in the picture how it can go for the training performing an emergency cricothyrotomy in a full mission simulation. So first is you can try it on the task trainer. Secondly, you can try full mission simulator. It is more realistic. And then thirdly, you can do on the real patient under observation, and after without observation you can perform. So this process is demonstration, then observation, then assistance and performance. These are the 4 steps in learning the skills. One more thing I told you about the high fidelity simulation. This high fidelity simulation determine the educational needs and choose most effective and efficient method of learning the skills. It need to balance resource availability and student demand, and may need to promote low technical solutions. So high fidelity simulator. It also confirm the teaching goals which can be achieved using the simulation. It develop the scenario, acquire the equipment needed and prepare the associated materials. The high fidelity simulator or simulation also test and validate the skills which you are going to acquire. The options for running simulation. There is a free form, easy but poor learning. On the fly form, which is scripted but intensive for the controller, and some variables may appear discontinuous. Then there is a programmed trends where more sophisticated simulations are possible. And fourth form is, or the fourth option is trends and event handlers, where the facilitates the high fidelity simulator with most realistic response and to the interventions. So whenever you go wrong, it gives feedback that this is wrong. So that is called as event handlers. Before and after simulation, there is a setting up of the scenario. For example, make blood, set up area, x-rays, notes, etc. It is also important, and this environment can be created real life scenario around the simulators. It can also load a computerized programmed simulation clinical scenarios. So you can load the simulation program, and there are various simulators which are having preloaded programs for different clinical scenarios or clinical conditions and the diseases. It can check everything works with the help of using cameras, VCR, communicator, recorder. And there is another room which is called as debriefing room, wherein it is shown to the trainer, by trainer to the learner, and whatever mistakes we have done during learning can overcome in the next session. Afterwards, you can check the simulator, replace or repair the parts if there, then clean everything used and put away, and replace, reorder all used items. So this is the things you should follow in the skill lab while learning the simulation. The high fidelity simulation allow time for briefing and familiarization with the patient simulator and equipment. It gives brief participants on broad objectives, the scenario and how to get help. So this is the picture which shows the real life scenario of the high fidelity simulator. It always follow the script but have alternative outcome planned and rehearsed. It also using simulation situation can be rerun to explore the outcome with different treatment plans. And the mission critical task can be performed by learners without putting patients at risk. The high fidelity simulation facilitated debriefing with an expert practitioner. Participants reflect on their own performance and discuss this with the group. So this is a debriefing room wherein what you have made mistake in the real life scenario on a simulator can be seen and discussed with the practitioners and the trainers. How we use the high fidelity simulators? It can be used in anesthesia, as an anesthesia, then emergency medicine, family medicine, general practice, coronary cardiac unit, intensive care unit, trauma or retrievals, paramedics, emergency medicine treatment protocol, then specialist nurses, medical imaging, pediatrics, rural health workers. So all these things can be used as high fidelity simulators. For you, the Medical Council of India, now it is National Medical Commission, that is NMC, they have given a skill module. This skill module gives you the whatever the certifiable skills which are important. So if you see here, this is a skill module and this document will be shared with you, which explains the how skills can be trained. So this skills training, these are the certifiable procedural skills which comes under the general medicine. For example, venipuncture, intramuscular injection, intradermal injection, subcutaneous injection, intravenous injection. All these are general medicine procedures which should be certifiable. All these you should learn in the skill lab. Then in general surgery we have basic suturing. You have already studied in the foundation course. Out of that, then basic wound care, basic bandaging, incision and drainage of superficial abscess, early management of the trauma, okay, and the early management trauma and the trauma life support. There are few orthopedics also, gynecology also, obstetric also, pediatric, forensic medicine, otorhino laryngology, ophthalmology. In each subject we have few certifiable skills and which should be learned during your course or respective phases. So this will be shared with you. Now today we are going to study the basic life support live demonstration. Hope with this sound foundation sowed, the seed will convert into a tree which is not only larger but it should give fruits as well. Thank you so much. Now I will बंद केलं.
Good afternoon, everyone. This session, that is adult basic life support. This session routinely we are taking mainly in skill lab. We are having a lecture, and routinely in this COVID pandemic we are not doing that thing, but routinely we used to take students to skill lab and make them practice themselves these skills that we are demonstrating. Now today's session will be on basic life support. I will be going through what is basic life support, what is the chain of survival, what is high quality CPR. I will give you show you BLS algorithm, AHA BLS algorithm, that is 2020 BLS algorithm, which has been updated last 3 to 5 months back only. And what are the changes in COVID, BLS sequence changes in COVID. Okay. First of all, what is BLS? It is a level of care which is used in a patient with cardiac arrest due to any life-threatening illness or injury until the patient gets the benefit of full medical care. Okay? So the main question arises is who can give BLS, when, where and how can we give this basic life support? Okay? Answer to first question is just anyone, any lay person can give basic life support. It may be a postman, it may be a farmer, an engineer or a doctor like us. When should you give BLS? It is at the occurrence of cardiac arrest. Okay? It is as early as possible because every minute of delay causes loss of heart muscle, and also if there is major delay, it will cause permanent neurological deficit. That is, patient may be in coma irrespective of reviving him from cardiac arrest. So it should be at the earliest. Where can we give BLS? It can be in marketplaces, at the occurrence of. It is at the occurrence of cardiac arrest or at the occurrence of collapse of a patient. It may be at the playground, meeting halls, or railway stations, or in airport settings. How can we give BLS? It is just staff training. That is, if you are trained in giving BLS, basic training, if you undergo, you can give BLS. Now next thing is, what is the adult chain of survival? Chain of survival is the steps that we take to make the patient survive. That is steps, what all steps one has to take. So normally there were 5 chains of survival. In 2020 they have updated it, and 6th chain, that is recovery, has been added in 2020 guidelines. So in case of hospital cardiac arrest, first chain of survival is early recognition and prevention of cardiac arrest. That is, there should be proper screening of the patient. One should give extra vigilance. One should be extra vigilant in patient who we think that he may go in cardiac arrest. That is preventive. That is, early recognition and preventive therapy should be given in pre-hospital. That is, in hospital settings. That is when patient is admitted with you. Okay. Second step, if such patient or if any other patient goes in cardiac arrest, one should activate the emergency response system whenever you detect a patient to be in cardiac arrest. Okay? After activating emergency response system, you have to start cardiopulmonary resuscitation. CPR is cardiopulmonary resuscitation. Okay? Before starting cardiopulmonary resuscitation, that is when you are activating the emergency response system, you have to tell them clearly that they should get an defibrillator. Defibrillator is the machine which gives shock, that is defibrillation. You may have seen those things in movies and all those things. So one should, whenever you are activating emergency response system, you should ask them to get an defibrillator. After that, you have to start CPR. Whenever defibrillator is available, you have to give shock as early as possible. You have to start compression as early as possible and also give shock as early as possible. The reason we will be discussing. After, when patient recovers from the cardiac arrest, you have to take care of patient. That is, you have to take his post cardiac arrest care also, and you have to give special precautions and special follow-ups for recovery phase. That is, patient may have some neurological deficits, psychological problems. So this recovery part has been added in these 2020 guidelines. Okay. If one faces a cardiac arrest outside the hospital, then chain of survival is same. Most of the parts are same. Only preventive and early screening part will not be possible in pre-hospital. It may be it would be a sudden event. Okay. So in that case, you have to activate emergency, give as early as CPR. Defibrillate whenever you get an defibrillator, that is automated external defibrillator, mostly in out of hospital setups. You have to transport the patient to hospital and give him advanced life support cares. Whenever patient recovers, you have to give post cardiac arrest care, and you have to give special attention for his recovery phase. So adult cardiac basic life support is, the steps are, you have to immediately recognize the sudden cardiac arrest and you have to activate the emergency response system. These are the two initial basic steps. So our aim is, these are the two aims, that is you have to give CPR as early as possible and you have to defibrillate as early as possible. You should not waste time in giving chest compression and also giving shocks or defibrillator whenever indicated. Okay. So first step is safety first. You have to take the patient away from the scene. So the steps of CPR are, you have to first of all verify that scene is safe, that you should not become the victim of the scenario, whatever the scenario is. It may be electrocution, drowning, anything can cause cardiac arrest or collapse. That thing you should look for, that what is the reason for him collapsing. Is there anything problematic around you, around the patient? Okay, so scene safety is very, very important. Second step is check for responsiveness. Then third steps come, that is when if patient is not responding. Over here these steps, whatever we are looking for are three vital organs, that is CNS, cardiac and respiratory. Whenever you are looking for responsiveness, you are checking his responsiveness, it is for his central nervous system. If he is not responding, his brain is not functioning, so he is not able to respond. If patient is not responding, it may be because of brain cause, heart cause or lung cause. Okay. So if any unresponsive patient, because of any reason, you have to call for help. You have to activate emergency response system. In India, it is 108 ambulance. You may be seeing those regularly. You have to call 108. If it is in hospital, there are dial numbers, code blue numbers specified for that hospital. You have to dial those numbers. If no one is there, if you are alone, you can use mobile device also. Okay. Next step is you have to check for pulse and breathing. If there is no pulse and no breathing, that is main cause is most probably due because of cardiac. So you have to start CPR in that case, that is in cardiac arrest case. Okay. After starting CPR, whenever someone is there to help you, you have to open his airway, give him rescue breaths in between the CPR, and whenever defibrillator arrives, you have to shock him as early as possible. Okay. So this is 2020 BLS algorithm. This has been shared on your WhatsApp group in our whatever group we have prepared. I have shared these algorithms. So first step is verify that scene is safe. Then check for responsiveness, shout for nearby help. If patient is not responding, activate the emergency response system. You can use your mobile device and tell them specifically that get an AED and emergency equipments. That is AMBU bag mask, if possible monitor, oxygenation, oxygen. Okay. Then if the next step is what have we observed, that whenever we are activating emergency response system, after that the first responder whoever has attended the cardiac arrest first, he will look for breathing and pulse. Pulse is very much important. You have to look for his pulse and simultaneously scan for breathing. How we have to do this, we will be demonstrating it after the presentation is over. So you have to look for carotid pulse. You can palpate your own carotid pulse just at the level of cricoid cartilage. Just slide your fingers in between sternocleidomastoid and this cartilage's airway. You will be feeling your carotid pulse. Okay. This is the place where we have to palpate the carotid pulse in case of adult cardiac arrest. If there is no pulse and no breathing, that is patient is in cardiac arrest, you have to start CPR. Okay. If patient is breathing and patient is having pulse, that is his respiratory and cardiac functions are normal, but he is unresponsive, then you have to just monitor. There may be some electrolyte or some brain cause of him becoming unresponsive. It may be hypoglycemia, anything. If patient is having pulse but he is not having breathing, then his CNS is not functioning, his respiratory is not functioning, but heart is functioning. That is, he is having pulse. That is the cause for him becoming unresponsive is because of respiratory. That is, he is not able to breathe, so he is not being able to oxygenate his blood. So he is not able to oxygenate his brain. They provide oxygenated blood to his brain. So that patient is unresponsive. In that case, this is the scenario of respiratory arrest. In that case, you have to just give him breaths, rescue breaths, one breath every 6 or 10 seconds. Okay? And every 2 minutes you have to check for pulse, that is he going in cardiac arrest. If he goes in cardiac arrest, you have to follow cardiac arrest algorithm, that is you have to give CPR. Now if in an unresponsive patient there is no pulse and no breathing, then comes your next step is, that is you have to start CPR. You have to give 30 compressions is to 2 breaths. This is the compression is to ventilation ratio. This will be shown to you. That whenever second responder or a basic life support teams comes, it will bring AED and ambu bag and all those things. That AED pads you have to attach as early as possible, and you have to analyze the rhythm. If that rhythm is shockable, you have to give shock. AED is automated external defibrillator. It will itself charge and it will just prompt you to give shock. Okay. If rhythm is not shockable, you have to continue CPR. Okay. If rhythm is shockable, you have to give shock, and after shock you have to give CPR for next 2 minutes. If rhythm is non shockable, you have to continue CPR for 2 minutes, and every 2 minutes you will be reanalyzing the rhythm. Whenever you are reanalyzing, if at that time rhythm is shockable, you have to give shock. If it is not shockable, you have to continue CPR. After shock, you have to again start CPR. Now pulse check, they are given the timeline, that is pulse check should not take more than 10 seconds. But they are given lower limit also, that it should be at least 5 seconds. Pulse check should be at least 5 seconds, but one should not waste more than 10 seconds in checking the pulse. Okay. If you are not able to check pulse, or in case of lay rescuers, they recommend even without pulse check you can start with BLS. Now how to start if there is no pulse, no breathing, and in a cardiac arrest patient? It is CAB, that is compression, airway and breathing. Compression, that is part of CPR, CAB, compression, airway, breathing. Compression will be given at the rate of 100 to 120. This is the rate, this is speed at which we will be giving compression. Okay, 100 to 120 compressions per minute. Such 30 compressions we will be giving. After 30 compressions, you will be giving 2 breaths. After 2 breaths, you will be resuming compressions at the speed of 100 to 120. That is 30 compressions in 15 to 18 seconds. Okay. After that, you will be giving 2 breaths. Those 2 breaths should also be given within 10 seconds. No more than 10 seconds of pause is allowed. Okay. Compression rate is 100 to 120, depth is 5 centimeters to 6 centimeters. Technique of compression is, you have to place heel of one hand over this victim's lower half of the sternum, place heel of other hand over the top of the first hand. The arm should remain parallel over here. It should be parallel. Hip joint should act as a fulcrum. You should give chest compressions at 100 to 120 compressions per minute, and depth 2 to 2.4 inch or 5 to 6 centimeters. Okay, so that all of the weight of upper body above hip joint will be transmitted to his heart. So heart will be compressed between the sternum and vertebral body. So in these two bony prominences you will be compressing heart, and this is manually you are doing manually you will be compressing the heart, and manually you will be generating some cardiac output. So to provide effective chest compression, you have to push hard and push fast. You have to allow complete chest recoil. That is, during relaxation phase you should not be leaning on the patient's chest, because this will hamper the venous return and this will hamper cardiac output also. That is, chest compression will be ineffective if you are leaning on the patient's chest. That is, so during relaxation phase also you have to be vigilant that you should not be leaning on the patient's chest. With 2 or more rescuers, switch should be occurring every 2 minutes. This 2 minutes is at the same time when we are analyzing the rhythm. Okay, every effort should be taken that switch should not take in 5 seconds. You should minimize interruptions. Next is airway. healthcare provider should use health tilt chin lift maneuver to open the airway. When health tilt and chin lift maneuver should be used when there is no suspicion of trauma, neck trauma basically. Okay, so this is the technique of head tilt and chin lift. You have to place ulnar side of your palm over the forehead and extend the neck. Okay, use your thumb and index finger to pinch the nostril of first hand. Then you have to lift the chin with 2 fingers of the other hand and keep the mouth open. After 30 compressions, you have to give 2 rescue breaths in this same position. Okay. Now, if there is suspicion of cervical spine injury or neck trauma, you have to open the airway using a jaw thrust without head extension. So you have to open. You should not give this head tilt and chin lift. You have to open the airway with jaw just extension, head extension. Now next comes breathing. Now breathing part. Is it running? Breathing. Breathing can be given. You have to look for compression, airway, and next is breathing. In breathing, you can either use mouth to mouth breathing, pocket mask breathing, bag and mask breathing, or with an advanced airway. Now mouth to mouth, you have to just same technique, that is head tilt and chin lift. You have to pinch the nostril and take a regular breath and seal your lip around the victim's mouth, creating an airtight seal, and deliver each rescue breath over 1 second. Use sufficient adrenaline to provide visible chest rise. So if you are alone and if the patient is known to you and if it is close relative or something like that, you can give this mouth to mouth breath. In an unknown patient, and if you are not comfortable basically, you can just give hands only CPR, you can just give chest compressions. Okay. Next type of breaths are pocket mask. These are the masks which 108 persons, those nursing staff will be carrying with them. Okay. You can, it just requires 5 to 10 minutes of technical learning. So you can easily learn this pocket mask, how to give breaths with pocket mask. Next is using ambu bag and mask. This also needs some training and practice. You can give ambu, you give breaths using this ambu. This is the ambu bag and the mask which has been held over the patient's face. You can give ambu bag breath using ambu bag mask also, or with an advanced airway. Advanced airways include laryngeal mask airway or combi tube, or you can also use endotracheal tubes. Okay, if a advanced airway has been already secured in patients, that you can use for giving breaths. Now giving this 30:2 compression breathing will be continued, okay, for 2 minutes. Whenever at any point, whenever AED arrives, whenever one gets an AED at the site of cardiac arrest, this should be used as early as possible. AED is automated external defibrillator. This AED will itself give you all the commands that we are analyzing the rhythm. It will itself analyze the rhythm. This machine itself will give you that this rhythm is shockable or non-shockable. Okay. So why should we use AED? Because in case of adult cardiac arrest, ventricular fibrillation is most common and easily treatable cause with a defibrillator. Okay. Survival is highest when CPR and defibrillator is given within 3 to 5 minutes of the collapse. So it has 2 AED pads. One has to apply one pad just below right clavicle and other in the infraumbilical region. These pads will be having images to which pad has to be applied at which place. So these are the shockable rhythms, that is ventricular fibrillation or ventricular tachycardia. AED itself will analyze the rhythm and give you command that rhythm is shockable or non-shockable. If you are having traditional defibrillator, and if you look at these types of rhythm, that is ventricular fibrillation or ventricular tachycardia, you have to shock the patient. If you are able to recognize that it is pulseless electrical activity, that is organized rhythm without an pulse, or there is a systole, flat line, in that case you should not give defibrillator. Now what are the steps of high quality CPR? These are, you have to start compression within 10 seconds, that is as early as possible. You have to push hard and push fast. You have to allow complete chest recoil. You have to minimize the interruption to less than 10 seconds. You have to give effective breaths, and you have to avoid excessive ventilation. Now how long should one continue? Till qualified help arrives or victim shows signs of regaining consciousness. Or if a lone rescuer gets exhausted, he may be forced to stop BLS. Now this is 2020 AHA. They are given, if arrest is not witnessed by emergency medical service person, or there is no return of spontaneous circulation before transportation, or there is no AED shock was delivered before transportation. If all criteria are tick yes, that is it was unwitnessed and there is no ROSC or no shock was given, then one can ACLS provider can take decision to stop resuscitation. If any of them are missing, you have to continue CPR during transportation also. Now this is the complete BLS algorithm. To revise, you have to verify that scene is safe, you have to check for responsiveness. If the patient is not responding, you have to shout for help, get and ask them to get an AED. Okay. If patient is, and then you have to check for pulse and breathing. If there is no pulse, no breathing, you have to start with CPR. You should give 30 compressions to 2 breaths. Whenever AED arrives, you have to give shock as early as possible if recommended, that is if AED gives you command, or if you identify that rhythm is shockable, you have to give shock. After shock, you have to continue CPR for at least 2 minutes. If rhythm is non-shockable, you have to continue CPR. After every 2 minutes, you have to reanalyze the rhythm. Depending on shockable and non-shockable rhythm, you have to treat the patient. Okay. So this is the main crux of basic life support. Now next comes about adult choking. This is one of the part of basic life support. So recognizing choking, if someone shows a sign of choking, that is universal choking sign, that is he cannot breathe, he cannot speak, you just have to reassure him and ask him, are you choking? You can ask him in your regional language. If he just nods, yes, he is not able to breathe and he is not able to speak also. If he just nods, then he is in choking. The treatment is you have to give him Heimlich's maneuver. The maneuver which has been shown in second, depicted in second image is Heimlich's maneuver. You have to place a fist of your arm just at the epigastric region, and you have to ask him to just lean down a bit, and you have to give him upward and backward thrust. Okay? Till object is forced out, or person can breathe and make sound and he says, yeah, it's out. Or person stops responding. In case person stops responding, that is that choking is severe enough to cause him hypoxia, and that hypoxia has caused him to be an unresponsive. In that case, you have to make that patient flat, make him lean down, call for help and start CPR. Okay? You have to call for help, check for breathing and give 30 sets of compression with 2 breaths. When you are giving 2 breaths, you have to check for a mouth, and if there is some foreign body visible, you have to remove. If it is visible, then only you have to remove. If you should not do a blind sweep. Okay? Now about COVID updates. This scene of basic life support in hospital involves nearly 4 to 5 persons. One patient is giving compression, one giving breath, one is monitoring, one is giving defibrillator, one is giving drugs, and all those things. If you are this scenario of cardiac arrest occurs in ICU or in hospital. But in case of COVID isolation ward or in case of COVID ICU, it has been recommended, these are the new updates in case of COVID, that first of all, whoever is taking care of the patient should be properly done and have proper safety precautions taken. One should limit the persons inside the resuscitation room also. Okay. So other update is that you have to prioritize oxygenation and ventilation strategy that minimizes aerosolization. Okay, you should use HEPA filter for all ventilations. You should intubate with a curved tube and connect to mechanical ventilation if available, ventilator if available. If intubation is delayed, consider using a supraglottic airway device also. Okay, and you have to consider resuscitation appropriateness. That what is the condition, what is the status of that the patient, what are the chances of that patient being recovering, how much time you have been giving CPR. You have to regularly consider this resuscitation appropriateness and address the goals of care in anticipation of potential need of increasing level of care. Okay. So these are the for COVID specifically, and they have followed prior guidelines. That is, this COVID was in 2019-20 we have seen, and at that time the guidelines were 2015. So they have just added some. The algorithm, background algorithm will be 2015 algorithm, and they have added the points which we should take care of. So at the point of verifying scene safety, they have added you should don't PP and limit the persons. Other parts are same. You have to look for the breathing or gasping. If the pulse is not felt and the patient is not having any breaths, you have to start CPR. You have to give 30 compressions to 2 breaths using bag and mask with filter and tight seal. Over here you can't use mouth to mouth breaths. Okay, or your pocket mask with filter can be considered of, but it should be avoided. Okay, bag and mask with tight seal, or continue compression with passive oxygenation using face mask, or you should consider advanced airway like supraglottic airway device or endotracheal tube. Whenever AED is arrived, you have to give shock and you have to repeat CPR after shock, and you have to repeat the analysis of rhythm after every 2 minutes. Now these are the references from which I have made the presentation. Thank you. Now we will be having a demonstration of basically how should one approach the patient in case of cardiac arrest. Okay. Our resident Dr. Sanket and Dr. Katyani will show you. Okay. Now, if Dr. Sanket is in marketplace and if some patient collapses in front of him, that is, he suddenly faints and collapses, how will he manage? He will just demonstrate.
First, I will see for scene safety. So, whole scene is safe. Now, I will check for response. Hey, are you okay? Are you okay? Please call emergency team and get an AED. Then I have to check for pulse and breathing. No pulse, no breathing. I will start for CPR. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 16, 17, 18, 19, 20, 21, 22, 23, 26, 27, 28, 29, 30.
Dr. Sanket is in marketplace or any function, and if someone collapses in front of him or faints and collapses in front of him, he will just demonstrate how will he manage that patient and how will he follow the LS algorithm.
First important is scene safety. So scene is safe. Then check for response. Hey, are you okay? Are you okay? Call emergency team and get an AED. Check for pulse and breathing. No pulse, no breathing. Starting with CPR. 2, 3, 4, 5, 6, 7, 8, 9, 10, 20, 14, 15, 16, 17, 18, 20, 21, 22.
सर थांबा.
So scene is safe. Check for response. Hey, are you okay? Are you okay? Call emergency team and get an AED. Check for pulse and repeat. Check for pulse and breathing. No pulse, no breathing. Starting with CPR. 3, 5, 6, 7, 8, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
9, 12, 14, 15, 16, 17, 18, 19, 20.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press shock delivered. Pause. Start CPR.
Thank you. So today we missed all these practice sessions in skill lab, but I hope you have understood how one should proceed in case of cardiac arrest, what all steps one has to follow. So thank you all. Thank you our resident Dr. Sanketan, Dr. Katyani. Now I hand over the stage to Dr. Akshay Shetty. He is intensivist and professor in Department of Anesthesia. He will be taking you forward to advanced life support. What one should do in advanced life support. Okay, thank you.
Thank you. Good afternoon, everyone. I'll be speaking about ACLS, that is Advanced Cardiac Life Support. I am Dr. Akshay Shetty, Professor, Department of Anesthesiology and Critical Care. Now, first of all, I want to congratulate all of you for taking the seat in MBBS, and I hope you will do the best for the society. Now, what you will know, till now, what did you know about CPR? CPR, it is having two components, that is BLS and ACLS. BLS is basic life support, and this BLS, you have already, Dr. Tushar has demonstrated about the BLS, and now I will be speaking about ACLS, that is Advanced Cardiac Life Support. Now, frankly speaking, it is asking a newborn baby to eat a full meal. For the ACLS, it is a very big chunk, and it is just for 30 minutes or 45 minutes. It is not good to complete this session, and I wish all of you to undergo the training course on AHA certified courses on BLS and ACLS, and by default, by the time of by the time you finish your internship, you will undergo all this hands-on training. So why we should know about ACLS? Because you already know about BLS, and now what about the ACLS? Yes, it is required to save the life of the patient, and in fact it may help for the saving the life of the your own relative also. Now ACLS is nothing but advanced cardiac life support. Just like a traffic signals, we have certain guidelines. So for conducting the ACLS or BLS, there are particular guidelines, that is European guidelines, American, and now we are coming up with the Indian guidelines for the cardiac life support. But as of now, we are using American Heart Association guidelines, and these guidelines are updated every 5 years. Now ACLS consists of, this can be applied for the child or the adult, but I will be speaking about the adult ACLS. Now this ACLS guidelines is not same for the adult and the pediatric. Obviously the doses and other things will differ. Now what we do in this ACLS, we are going to use our cognitive and technical skills, and we will be using certain equipment, certain drugs, emergency drugs, and you have already seen this AED, and inside hospital we have the defibrillator, and we will be using ventilator support for saving the life of the patient. Now there is something called a chain of survival, which Dr. Tushar has already told about this in BLS, I think, and this is nothing but we will be using the outside hospital chain of survival, that we are going to activate the emergency system and start doing the high quality CPR and defibrillate as soon as you get the defibrillation, and advanced type of resuscitation, you ship the patient to the hospital, and post resuscitation care and recovery is the chain of survival. If it is inside hospital cardiac arrest, early recognition is very important, and immediately you have to activate the emergency system, start doing the high quality CPR, defibrillate because it is easily available inside the hospital, and do the post cardiac arrest care, and there will be recovery of the patient. Now I think Dr. Tushar has already told about the reason for the cardiac arrest. You can just remember 5UT and 5UH as a mnemonic. And this is the algorithm which is being proposed by the AHA in 2020. This is the latest guideline. I'll speak a little bit about the algorithm. Now in stepwise, where as you know the same BLS part, now it is continued as the ACLS, and the CPR will be continued. And for this, for the patient or the victim, you are going to give the oxygen and attach the monitor or the defibrillator. The moment you attach the defibrillator, or you have to see whether the patient should receive the shock or no. You should give the oxygen and apply the monitor. In the monitor, you should see the ECG. Now, after saying if patient requiring the shock, that is a defibrillator, I think you might have seen in certain movies that some person is giving shock to the patient. That is a separate machine. It's not just electrical supply. It's a different thing. Now defibrillator is nothing but it is not going to stimulate the heart. Okay, it is going to defibrillate. If you split the word defibrillate, the fibrillating heart is being stopped. And SA node, you will learn about the SA node and other conduction pathways about heart in physiology and anatomy. So this SA node will overtake the function of the heart. So for example, this is how the normal heart beats, and you can see the ECG in this. Okay, and this is how the ventricular fibrillation occurs. You can see the ECG and you can see the contraction of the ventricle. This is the cross section of the ventricle. It's not an effective contraction, so that there is no cardiac output. The moment you give the shock, it will be converted into normal heart rate. Okay, normal heartbeat. Okay. Now this is again one more scenario. This is called a ventricular tachycardia. You can see again it is a abnormal contraction. This is in this condition where when there is no pulse but there is a ventricular contraction, and you can see the waveform in the monitor. That is pulseless ventricular tachycardia. That time you have to give the shock. And how much energy we have to use? There are two types of a defibrillator. That is a biphasic and monophasic. Monophasic is a old variety of a defibrillator. Biphasic is nowadays it is used. Biphasic type of defibrillator. You can choose the highest. There is no need to go in depth what type of defibrillator it is and how much energy we have to use and all. So there is no need. You can just make it a maximum current you have to select, maximum joule you have to select, and then give the shock. And next step is the moment you give the shock, you are going to continue with the CPR for the 2 minutes, and you have to ensure that you are going to put an access for intravenous cannula, that is to give some drug or medications if required. If it is not accessible, you may have to put the needle inside the bone also, that is called as intraosseous. Now we have completed this 2 minutes of CPR, and you have checked for the rhythm. If it is not shockable, if it is shockable, we are going to give the shock, and if it is not shockable, then we are going to use some drugs. Shockable, in shockable type of rhythm, we are going to restart after giving the shock. We are not going to wait whether the heart is reverted back to the normal state or no. We are going to continue the CPR for 2 minutes and assess the heart rhythm. Again, if there is a shockable type of rhythm, then again you are going to give the shock. So CPR for 2 minutes and reassess whether patient requires one more shock or no. If requires one more shock, then continue with the shock and then continue with the CPR. This cycle will continue. And if it is not a shockable rhythm, and if patient requires adrenaline, that is the drug, emergency drug, adrenaline, amiodarone or lignocaine, you in future you will learn all these drugs. So those drugs are given. Okay, this is the left part of the guidelines which we have completed. Now if there are no circulation, if the heart is not pumping very well, that time we are going to give injection adrenaline. That is to be repeated, 1 milligram has to be repeated every 3 to 5 minutes. And we have to consider for the advanced airway, I will speak about it. And that after that you have to continue with the CPR for 2 minutes. Now this left part we have completed. On the right hand side, okay, there is something called as if the rhythm is not shockable, especially if the patient is in pulseless electrical activity or asystole. Asystole is nothing but its heart stops beating, and in the monitor you can see the flat line and the heart rate is recorded as 0. At that time epinephrine or adrenaline 1 milligram intravenously it is injected. It has to be injected every 3 to 5 minutes till the rhythm appears. And we have to consider advanced airway and capnography. Advanced airway management means we are going to put some artificial tube inside the trachea, that is windpipe from which we breathe. So these are the equipment which are required for putting endotracheal tube. So these are called as supraglottic airway devices. These are nothing but just above the voice box. These equipments are placed inside the mouth of the patient and oxygen is delivered to the patient. So you can see in the picture. Now capnography is one of the important component in the ACLS. That is, it detects the carbon dioxide from the expired air. We inhale oxygen and we exhale CO2. That is carbon dioxide. So this will help to confirm that whether the device is placed properly or no, or else whatever the oxygen is given to the patient, it may enter inside the stomach, which is not good. So you can see the capnography or EtCO2 end tidal carbon dioxide monitoring in a monitor. Now how much breath we have to deliver? So once endotracheal intubation is done or supraglottic airway device is given, one breath should be given every 6 minutes. That is nothing but 10 breaths per minute. But we should not avoid the chest compression. Chest compression has to be continued. And keep a watch on capnography. Now again, after these maneuvers we are going to check for the rhythm, whether it has to be done simultaneously. If rhythm is shockable, then give the shock. If it is not a shockable, then continue with the CPR and keep giving the adrenaline. And always remember that you have to do the high quality CPR, that is nothing but push hard at least 2 inches, that is 5 centimeter, and fast 100 to 120 per minute of compression, and always allow the chest to recoil so that the peripheral venous circulation is like there will be pooling of the blood inside the heart, and minimize the interruption in compression and avoid excessive ventilation. Don't give breaths more than 10 per minute. If there are 2 or 3 people, keep rotating among yourself so that only one person will not do continuous CPR and get fatigued. If there are no advanced airway, then maintain 30:2 of a compression and ventilation ratio. And quantitative waveform capnography, and keep observing about the endotracheal end tidal carbon dioxide monitor, which will you can understand, like if there is CO2 is eliminated from the lung, it means that the compression is very good, the blood circulation is maintained very well. So once there is a return of spontaneous circulation, you will be able to feel, it means that the heart has started contracting on its own. You can feel the pulse of the patient, especially the major blood vessels like carotid or the femoral, or you may be able to see the auscultate and hear the heart sounds. So that is nothing but return of spontaneous circulation. So when to stop this? Once the patient is having a return of spontaneous circulation, that time you can stop, or as a protocol we are stopping, at least we will be doing for ACLS for 45 minutes minimum. So it all depends, like you can continue more than that also, but the outcome are bad even after 45 minutes if you continue with the CPR. So this is about the CPR in the ACLS part. I feel all will get trained for this CPR part. The moment you people come, especially once you get the clinical postings and once you are entering in the internship phase, and you will be able to see the patients, and certain unfortunate things may happen in the ICU especially. That time you will be able to see and you may do hands-on training directly on the mannequin or on the patient also. So this is about the CPR in ACLS. Thank you so much. I wish you all the best.